It's a pleasure to be able to talk with you. I wasn't sure exactly who's going to show up, and so what I've kind of done here is I've tried to divide the care of carotid patients into pre-op and post-op. So I hope that makes sense. If we've got floor nurses, there's a chance that you would be, say, recovering a patient today or dealing with a patient today that's going to the operating room tomorrow. So a couple things come to mind. One, in this day and age, there are a lot of people on anticoagulants. You know, there's Coumadin, there are the direct thrombin inhibitors like Xarelto, and there's Plavix. And all these things have half-lives. Different surgeons have different attitudes about anticoagulants. In some patients, you can literally take them off of anticoagulants without too much risk, and some you can't. If somebody had a drug-eluting stent, for instance, fairly recently, then the cardiologist may be insistent that that patient be on Plavix. So if you've got to do carotid surgery, you don't have a choice of stopping it. You just got to operate through it. If, on the other hand, I see a fair number of patients in the hospital that have had strokes. And if somebody's had a stroke, they're put on aspirin and Plavix, but maybe 2 weeks later or 3 weeks later, somebody like Dr. Devlin would be happy or okay with stopping it to have surgery. Generally speaking, with Plavix, you need 5 days to be off Plavix to get the effect out of your body, or maybe 7. Anesthesia like 7. We generally say 5. Coumadin, you know, if you're trying to come down off of a reasonable INR of 2 to 3, Coumadin, you need maybe 3 days to be off of Coumadin. Aspirin, we usually leave them on. Xarelto, you need, and those types of drugs, you need 5 days to be off. Now remember, with the direct thrombin inhibitors like Xarelto, and there are several others out there, you can't reverse them with platelets, and you can't reverse them with fresh frozen plasma. So it's really important, if they're on those kind of drugs, that all be addressed ahead of time. Now, a lot of times surgeons are going fast, and we don't look at the MAR, so we don't know whether somebody's on anticoagulants sometimes. We ought to be better than that, but somebody like Marcy could be sitting there on the floor, and I could blow through there and say, okay, I'm going to sign you up for a carotid tomorrow, and she could call me and say, did you know that this patient's on Plavix? Now, that wouldn't make a big deal to Dr. Sprouse. He operates through Plavix all the time. But if you ever do any work with heart surgeons, they're insistent that somebody be off of Plavix if they're going to have a pump run. So different surgeons have different thresholds to operate on people that are on anticoagulation. So I just mentioned that because if you're on a floor and you got a patient, or you're in same-day surgery or something, and somebody comes in and you can see they're on anything other than aspirin, you might want to call the surgeon and say, do you know that they're on this medicine? And if they are, at that point in time, you could cancel the operation if he thought that was the best thing to do before they open up a whole operating room worth of stuff and basically open up an operating room at an expense of about $1,000 that kind of has to be canceled. The second thing is that you need to look at somebody's neurologic exam. And somebody needs to document that. Now, typically that's not the nurse, but I'm just saying, if somebody's had a stroke, it's important that somebody document the side of the stroke and what the defects are. Now, some people have actually had strokes, and you can have MRI defects, but yet they don't have any clinical manifestations of that stroke. But if somebody has a hard time with moving their right hand and their right leg, and they're having some speech difficulties, it's nice to document that you probably had a left hemispheric stroke with what the manifestations are, because after surgery, if everybody's scurrying around trying to figure out whether the arm weakness is new or old, it's helpful to have a baseline neurologic exam. The other thing, this may be more of an issue in previous years, but if somebody has their blood pressure well managed pre-op with a carotid, post-op in the recovery room, their blood pressure is usually a lot easier to manage also, and it's also easier to manage on an operating table by anesthesia. In the old days where we used to use something called Aldomet, which you don't see too much anymore, alpha-methyl-dopa, you really needed to load patients on that for a couple of days before it started having the antihypertensive effect. And you would see people that were maybe on that drug that weren't taking it or weren't taking it right, and they'd come in the hospital and they'd have marginally high blood pressure. If they had a marginally high blood pressure and you put them to sleep, then their blood pressure went even higher, and now anesthesia is playing with drips in the operating room to try to bring it down while you're doing the carotid. It's a lot better if you get the blood pressure under control on a pre-op basis. Then anesthesia, blood pressure management on the table is a lot easier, and then the recovery room nurses' blood pressure management is also a lot easier. So now that's pre-op. Does anybody have any questions about that? Anybody have any questions about that pre-op? All right. There are basically two ways of doing a carotid endarterectomy, and I'll also try to address carotid stenting because there's more and more carotid stenting going on. Dr. Lassar is the only one of us, there are 8 of us that do vascular surgery in my group, and I guess we do 99% of most of the vascular surgery in town, and we probably do 95% of the carotid work. But Dr. Lassar is the only one that does carotids under a cervical block or basically a local carotid. And the reason he likes to do that is that he likes to ask questions during the operation to make sure that the patient's hemisphere he's operating on is working. And so basically anesthesia kind of puts them in that twilight zone with things that don't really knock them down, and then you ask them questions. You ask them questions like, can you squeeze your right hand if you're operating on the left carotid? You know, stick your tongue out, do this, that, and the other thing. He likes that. He's the only one of the 8 of us that likes to do carotids awake. The other 7 of us do carotids asleep. And there are a lot of reasons why I do carotids asleep, but one of the things is I don't like people to move. There are critical parts of that operation that really need to be very precisely done. And if somebody's moving around, they get a little hypoxia, they get a little antsy, and they've been lying on their back for an hour, and they said, my back is killing me, I got to move. They invariably do that just when you don't want them to do that, and I can't stand that. So I put everybody to sleep. I've been doing that for 35 years, and I'll put my record on carotids up against anybody. So I don't think the general anesthetic makes any difference one way or another. What Dr. Lassar is trying to figure out a lot of times is whether he needs to use a shunt to get blood from the common carotid up into the distal internal carotid and up to the brain. And if he clamps a carotid and the patient's awake and he asks them to do maneuvers and they answer questions, then he can tell whether that hemisphere is doing okay or not. If the patient, goes out, like turning off a light bulb, then he puts a shunt in real quickly. Well, I put a shunt in most people anyway. And the other thing I would suggest to you that if you put the brain really to sleep with a deep anesthetic coma, the metabolic demands of the brain are less, oxygen requirements to that brain are a little bit less, and I think that gives me a margin that he doesn't have because his patients are awake and mine are always asleep. So anyway, we could argue that one all day. I'm not here to argue whether he's right or I'm more right. He gets good results, I get good results. We just do it a little differently. But understand, he's putting a local anesthetic into the neck. There's no other way he could do it. And so when you get somebody back in the recovery room, you've got to take into account the fact that they may have some things blocked with the nerves with a local anesthetic that I wouldn't have. So if somebody comes in, I remember one time I've done, 8 or 10 local carotids in my life. And the last one I did, I swore I'd never do another one. I haven't. But somebody was telling me that they couldn't pick the shoulder up. Well, I'd put so much local in here with the cervical block, its whole brachial plexus was blocked. I did so few of them that for a second or two there, I was panicked that I had done something wrong. I wasn't sure what I had done, but it was the local anesthetic. Just understand, if you're in the recovery room, you're a recovery room nurse and you're getting a carotid, you've got to take into account where the local anesthetic went and what nerve it may have blocked because it may not be working. So if you're worried that a nerve's not working, it may have had a stroke. It may not be the stroke at all. It may just be the local anesthetic. When anesthesia drops a patient off in the recovery room, I think it would be an interesting question to ask, how has the blood pressure been to manage? Carotids are notorious for having blood pressures that go up, and carotids are notorious for having blood pressures that go down. And there are 2 different mechanisms. Depending on how deep the patient is, from an anesthetic standpoint, sometimes they just have neck pain. Sometimes they don't like an endotracheal tube. And so that can make blood pressures go up. It can also make them go up if they're not well treated preoperatively with antihypertensive medications. And so anesthesia, if you look at any carotid that's ever done in this hospital, you're going to find an art line in almost every patient, including the carotid stents. And you're going to find 2 drips that are already mixed and they're right there. Whether they use them or not, it's a different deal. But there's going to be a drip that's going to have some nitroglycerin in it probably as a vasodilator. It's going to have something like neosynephrine in it, which is a vasoconstrictor, depending on which way the blood pressure goes and which way they need to treat it. So I think that if somebody was really hypotensive for most of the operation and they were trying to boost the blood pressure up, then in the recovery room, you're going to have similar issues. On the other hand, if somebody was hypertensive on the operating table for most of the case, and they dump them in the recovery room, then you're going to have problems with high blood pressure, and you're going to have to treat that. Now, differing doctors kind of have different philosophies on whether patients go to ICU after surgery or not. And in the hospital where I trained a long time ago, we didn't have that many ICU beds. We had a lot of them, but a lot of those beds were occupied by trauma patients. And if we were going to do carotid surgery, we tried not to put people into ICUs post-op. Obviously, the issue with the post-op carotid, one of the issues is, does their neurologic exam change from whatever the baseline is to something different from baseline, so that you need to be on top of it so that you can run somebody back to the operating room and try to fix a technical problem, if one exists, to try to prevent a stroke from being a fixed stroke. Well, based on 35 years of doing this, I can tell you that almost all of the carotid problems that you're going to find from a neurologic standpoint, you're going to find in the first 3 hours. Now, that's not to say I've never seen a carotid neurologic problem happen after 3 hours, but I'm saying the few that I've seen, I haven't seen that many because I guess I've just been lucky, but the ones that you see, you almost always see within 3 hours. So that's the reason that I put my carotids in the recovery room with instructions. I want them to stay here for 3 hours. If their blood pressure management's good, there are no other issues, the neurologic exam is stable, I send them to the floor. A lot of these patients are old, they can sundown. If they go to the floor, they got windows in the rooms for the most part. They got family that can spend the night with them. They don't sundown as much, and a lot of the older patients do better. And we're operating on a lot of people in their late 70s and 80s too for this operation, and occasionally in their 90s. That way, if I send somebody to the floor, then they've got an empty ICU bed that night to put a trauma patient in, or whatever kind of patient you want to put in there. So for all y'all that work in an ICU setting, if you don't see my post-op carotids, there's a method to the madness. I try hard not to send them to ICU. I find that for the most part, they don't need it. It's more expensive, and it takes up a bed that then we got to worry about in the middle of the night who's the least sick patient to move out on the floor so we can put a sicker patient in an ICU bed. And if you know what's been going on in the emergency room over the last 2 or 3 months, you know, they've got holes every night, anywhere from 10 to 30, and a lot of those people looking for ICU beds. So my point is, why put a carotid in an ICU bed? I mean, generally speaking, 6 hours after carotid, they're up eating, they're doing all that kind of stuff. This is Dr. Blaylock trying to get me, but so I just don't put people in ICU. Now, almost everybody else does that, and they think I'm crazy, I'm cavalier, I'm a little bit out there to put people out on the floor after 3 hours. I guess I'm a product of where I trained. It works for me. I do it at Memorial, I do it at Park Ridge, I do it earlier. It works. Now, if they're going to the floor, though, you've got to have a neurologic exam that is baseline for that patient. Remember, if they've had a stroke, you've got to take that into account. Because if they had a stroke going into the operation, they're going to have a stroke-like symptoms after the operation, obviously. And their blood pressure has got to be fairly stable. So if you're on a blood pressure boosting drug, such as dopamine or neo, then they can't go to the floor, and the same with the vasodilator. A little pearl I'll throw out there to you if you're ever dealing with a carotid patient. Sometimes I have been called and said, you know, this patient's blood pressure is really high and it just won't respond. And a lot of times, particularly with men, and there are more men that have a carotid operation than women, if you don't put a Foley catheter in, anesthesia really fills them full of fluid. They go straight to their bladder. They basically go into urinary retention, and they're sitting there in a ton of pain, mainly because they've got a full bladder. If you'll put a Foley catheter in them and leave it for 6 hours and let all that fluid come through their system, you'd be surprised what will happen to their high blood pressure. It'll settle right down, and they'll be happy, you'll be happy, and you can still send them to the floor.
What about a straight cath? You know, we're preaching to these guys every day about Foley's.
Yeah, I know you are, and in my experience, in that setting where somebody, see, with a carotid operation, look at the blood loss that I typically have. I mean, it's rarely more than 200. A lot of times it's 100. And the thing is, anesthesia, a lot of these people come in for a carotid operation and they're dry because they've been on diuretics. And so anesthesia is sitting there on a table, and what anesthesia is trying to do is they're trying to get some urine output, or they're trying to treat this, that, or the other thing, and they're flogging them with fluid. And the problem is, if you do an in and out cath in a recovery room, then you get 600 cc's out of the bladder, and then you pull the straight catheter out, and then all of a sudden they got 400 cc's back in there 10 minutes later. And now they're sitting there flat on their back. Men can't pee flat on their back a lot of times. They got prostate problems anyway. It's been my experience, put the Foley in and decide you want it out in 6 hours, 8 hours, and just get somebody to DC it on the floor. And by that time, a lot of the fluid that anesthesia is giving us come through the system. That's my thought. I don't put Foleys in much anymore. So if you see my patients coming to the recovery room, you're going to find a lot of even male patients don't have Foleys. So it's up to you to figure out if they've got pain. And you can always ask a guy, how does your bladder feel? If he says, oh, it really hurts, then okay, there's the light bulb should go off. This guy probably needs at least an in and out cath with a straight catheter. But I would put it in a Foley and just leave it for 6 hours or so. Another issue that you're going to see is swelling. Now, everybody swells a little bit. And everybody kind of has an incision that looks like it's kind of a rooftop incision. That's the way we sew things together. But remember now, almost all these patients are on aspirin at a minimum. Some of them are going to be on Plavix. 70% of people on Plavix get an anti-platelet effect, 30% don't. But I'll never will forget one of my senior partners, who some of you older people may know, Joel Clements, the first time he ever did a carotid endarterectomy on Plavix, he didn't even think about it. He spent over an hour in the operating room after he'd finished operating just trying to dry a neck up. And he walked out of the operating room. I saw him right after that. And if you knew Clements, he was going off like Joel Clements could only do, saying, I will never operate on somebody again who's on Plavix. And I really don't like to do that. But now other people don't seem to mind. But I'm telling you, it is very frustrating when everything in a neck oozes. There's no suture line to put a stitch in. It just oozes. And that's what you see with Plavix. So I'm just saying that if you need to be watching for oozing. Now, a lot of patients come out of the operating room with a drain. I put a drain in almost every one of mine. The other thing that happens on the operating table is most of us give heparin. Almost everybody gives heparin. The typical dose of heparin is about 5,000 units. And usually it's a one-time deal. The half-life of heparin, nobody really knows what it is. I've heard some people say it's 40 minutes. I've heard some people say it's an hour and a half. But anyway, let's just say that at the end of a carotid operation, most people have been through about one half-life of heparin. So that means there's still some heparin circulating. I got out of the habit of reversing heparin routinely with protamine a long time ago. So most of the time I give heparin and I don't reverse it. I just let it dissipate. So I might actually put somebody in a recovery room setting with heparin still circulating. That's one of the reasons I put a drain in the neck. But don't think just because you don't see blood coming out of a drain that there's no bleeding in a neck. Most of the time a drain's there to help you with the bleeding, and if all of a sudden you start seeing a bunch of blood coming out of that neck in that drain, then you need to get in touch with somebody quickly. But drains can also clog up. So a drain can be a false signal to somebody that You say, oh, well, they can't be bleeding because there's nothing coming out of the drain. Well, that's wrong. Particularly those silastic things. You know, you can milk them. You can put the KY jelly on the little tubing or the alcohol swab. So anyway, that can give you a hint, but it's not always a perfect hint whether somebody's bleeding or not. I've had 2 or 3 pretty interesting problems with neck bleeds. I mean, not all of them need to go back to the operating room, but one of the reasons that you need to watch somebody pretty intensely for the first 3 hours is if they're going to have a neck bleed, that's typically when they're going to have it. And the other problem is, remember, if you get a lot of swelling in the neck, let's say you did a left carotid, now you can deviate the trachea, you can have some breathing problems, and some of those people need to go back in a hurry. So at least if somebody's oozing, people need to be aware so they can come by and the surgeon can kind of look at it, or the resident can come look at it and see what it's like now, and see what it's like 30 minutes from now, and see what it's like an hour from now. And if somebody thinks they need to go back, then they need to start opening up an operating room, which takes a little bit of time to get back in the operating room. And sometimes all you do is explore that neck. You never really find a bleeder. Sometimes you find something, put a stitch in. But that would be more in a recovery room setting. Now, if somebody's going to an ICU, then they may only stay in the recovery room for an hour. That's pretty typical. Then they may go to the ICU, and so the onus then is on the ICU nurse, because then they said, you know, there are things that can happen between hour 1, post-op hour 1, and 3, 4, and 5, like neck swelling and bleeding. So just take that into consideration. If you're working in a recovery room, you're working in an ICU, you're not going to have the luxury of having examined a patient pre-op. So I think it's important when somebody brings a patient into you that you ask the question, has this patient ever had a stroke? If the patient hasn't had a stroke, that's valuable information to you, because if they start showing signs of neurologic deficits, then you know it's new and you need to get in touch with somebody immediately. If, on the other hand, the right arm was weak before they ever had the carotid endarterectomy done, and they've had a left hemispheric stroke, and the right arm is weak in the recovery room or an ICU, then that's to be expected. And nobody needs to get too antsy about that. The other but the other pearl I'll throw out to you is, remember that a stroked out hemisphere is going to wake up from a general anesthetic slower than a non-stroked hemisphere. So on an operating room table, sometimes when somebody's had a fairly significant stroke, you know, they pull the tube out, a lot of times the hemisphere that's had the stroke is not going to wake up very quickly. So you might think that the arm is denser in a form of paralysis than it was pre-op. If you just give it a little time, then that hemisphere will wake up and you'll go back to baseline. Remember, around here now, it used to be that most of the carotids I was doing were asymptomatic carotids. You were trying to operate to prevent a stroke. Now, with the stroke program like Dr. Devlin has, I evaluated 2 of his patients yesterday that came in over the weekend. One's in SSU, one's up on the floor on 7, and both those patients have had fairly significant strokes. And yet I'm going to be operating on them. One of them I'm operating on today with a smaller stroke. One of them I'm going to do in 2 or 3 weeks. That's what one of these calls is about. And so there are a lot of patients we're doing carotids on these days that have had strokes, because this is a stroke center. And that's how you discover a lot of this carotid stenosis. People refer it into somebody like Dr. Devlin. Pain in general is not a big feature of carotid endarterectomies. I mean, the neck incisions don't hurt that bad. And a lot of my male patients that I operate on don't even go home on pain medicine the next day. So if somebody has a lot of pain, that would make me wonder why they have so much pain. And I guess one of the things I would wonder about is whether somebody has sewn up a neck and there's a bleed inside, and somehow or another the blood can't get out through the drain, or maybe they didn't drain it. I mean, in the olden days, if I reversed with protamine and I thought the neck was pretty dry, I didn't routinely drain patients. And now, you know, protamine's a pretty powerful drug. If you've ever worked in an operating room setting, if you've ever given protamine, particularly if you have a swung against catecholamine, you can see some pretty interesting pulmonary artery measurement changes when you give protamine. And you can also develop antibodies to protamine. So I've kind of gotten out of the habit of giving protamine. I just let that help them dissipate. So Patients frequently are going to come back to the recovery room with anticoagulants going, so just be aware of that. We have not yet, in this area, done same-day surgery on carotids. They've done it in California. So if somebody comes in at 8 o'clock in the morning, has a carotid, and they're in the recovery room at 10, you watch them all day long until 6 or 7 or 8 at night, and if they're otherwise stable, you send them home. I've often thought about doing that, particularly when they're just doing absolutely great. And I see somebody in the back who's saying, oh gosh, I just can't imagine you do that. But think about it this way. We do a fair amount of carotid surgery starting at 5. I've got one to do today that I'm starting about 3. So she'll be out at 5, 12 hours later, it's 5 in the morning, we send them home the next morning. 12 hours from 5 at night, 12 hours from 8 in the morning, what's the difference? See what I'm saying? It's still the same 12 hours, it's just a matter of do they spend the midnight in the hospital. And in this day and age of hospitals trying to get people through the system faster, you're probably going to see that in selected cases. There are a lot of people that won't be willing to do that, but I probably will, if somebody's really looking that good. Now, I've kind of mentioned a whole lot of things, and I don't know whether I've told you anything that you didn't already know. Who's got a question?
Two things, I don't know if because I was a little late, if you talk about selection criteria for surgery for carotids, and then the other thing is hypoperfusion syndrome.
Great, thank you for reminding me on that. Let's go to hypoperfusion syndrome first. You don't see it very often, but think about it this way. If you've got a brain that's got a carotid stenosis, that brain is basically ischemic. And the blood vessels in the brain are maximally vasodilated to try to get blood up through a stenosis. So post-op, if I clean out that carotid bifurcation like I do, now you've probably got 3 times the blood flow coming up that carotid artery that it used to have, and so that brain is going to have 3 times the blood flow it used to have. Well, the blood vessels up there have lost their ability on a temporary basis to vasoconstrict because they're maximally vasodilated. So with all this blood flow coming up to that hemisphere might get a reperfusion or hyperperfusion syndrome, which consists of edema and swelling. Classically, that happens on about post-op day 3, 4, or 5. I'll tell you a funny story in a minute. But I have seen it recently in a recovery room. And where you see it is typically in somebody who was really hypertensive pre-op, somebody who had a really tight carotid pre-op, like a 90% or worse, and maybe somebody who also gets headaches. And in the recovery room, if they have a really splitting headache on the side of the ipsilateral to the carotid you did, and I see that in the recovery room, then typically I treat it. Now, the way you treat it, the first thing you want to do is you want to make sure that the blood pressure is reasonable. And that's one thing we didn't talk about. One of the things that I do, I find it easy to give somebody a mean blood pressure. They've got an art line in, the blood pressure machine up there will give you a mean blood pressure very easily. And I like to keep my mean blood pressures on post-op carotids between 70 and 90. It works for me. It's not all that unusual that you see somebody developed a post-op bradycardia and their blood pressure drop below 70, and it's not all that unusual that you see a mean blood pressure that's above 90. And typically, if it's high, I treat them first with nitroglycerin if I can get it down. And then you can go to Cardine or you can go to Nipride. If it's low and you need to get their blood pressure up, a favorite for anesthesia is neosynephrine, but it's a vasoconstrictor. I kind of prefer dopamine. But anyway, either one of them works. But with the reperfusion or hyperperfusion syndrome, the first thing you want to do is you want to get the blood pressure down in a reasonable range, certainly below 90 mean. And the second thing, if you still think that they've got the headache, the splitting headache, the worst headache of their life is the way that they describe it. If you've got that, then typically what I do is I load them with Dilantin, because those patients can go ahead and have a grand mal seizure. And Dilantin seems to relax the blood vessels that are causing the headache, and all of a sudden their headache gets better and everything seems to get better. And then I run them on Dilantin PO for about 4 to 6 weeks and then just stop it, and they almost all do fine. But I did have a patient one time that came in the office, it must have been 15 years ago. I did a carotid on a Sunday, sent them home on Monday. She came back to see me in the office Thursday. Said she had the worst headache of her life. I thought she was a crock, and I blew her off. And she left my office, went home, walked to her front door, and had a grand mal seizure. It was a patient at Memorial. She was taken back to Memorial, admitted by a neurologist, did a CT scan, looked great, no stroke. Got me to come back and see her. I said, well, it's reperfusion. And she said, I've never heard of it. I said, well, we don't see it all that often. I guess you'll probably see it once every 50 patients. Okay. Yes.
Yeah, I was going to make a comment about that, if you weren't going to address it. I did take care of a patient many years ago that had a carotid. They were in an SICU. I had her packed up to go to the floor, and probably about 15 minutes before I was going to transfer her, she started with a burst of seizure that went into a grand mal seizure. And she made it. We loaded her up with Dilantin during the code. And you know, it's the only patient I've ever taken care of that's had a carotid that had a grand mal seizure. And I believe she was maybe 2 days post-op.
Well, if she didn't have the headache, then I don't know that that was reperfusion or hypoperfusion syndrome, but it happens.
From a clot.
Yeah, sure.
I don't remember what type of
Well, she could have had a previous stroke also, and it's all of a sudden that was her day to have a seizure.
She was a very large woman, so she had a high predisposition
Okay.
to stroke. But it was, you know, I mean, it just took me by surprise. I'm so glad I wasn't on the elevator with her.
Right. Angela, you said something about you want pre-op, the indications.
Yeah, the criteria, and also about with the reperfusion syndrome, what I've seen is it's really the unilateral headache is kind of the pattern.
Yeah, that's right. On the same side as the carotid. If it's bilateral, it's not reperfusion syndrome. So I guess you're asking who is a candidate for carotid endarterectomy? Well, I think that there are two big classifications of people that get carotids. There are those that are asymptomatic and those that are symptomatic, and I'll try to discuss them differently. An asymptomatic patient is basically somebody that most of the time is picked up with a carotid bruit, and there are a lot of people out there with bruits. But a lot of people with bruits get carotid ultrasounds, and provided that the ultrasound is done and it's a high quality ultrasound, and that's a big if because there are a lot of ultrasounds done throughout the country that are not high quality. But an ultrasound costs about $250. It doesn't involve any kind of contrast. It doesn't involve sticking needles in people like an arteriogram, anything like that, but it needs to be done well by a tech who really knows how to do a carotid study, and it's a tricky study to get done because there are all sorts of angles and things that have to be met to really have a valid study. But provided that the carotid the ultrasound is a valid study, if they've got a 70% stenosis, which is judged by flow velocities. There are different categories for flow velocities. The higher the flow velocity, the greater the degree of the stenosis. If they have a 70% stenosis or greater, most of us will go ahead and do a prophylactic carotid endarterectomy trying to prevent a stroke. And that's all based on the ACAS study that was done and published about 1994, and that's when a lot of asymptomatic work started being done. Now, there are also the symptomatic patients, and symptomatic patients, you wouldn't see so many symptomatic patients at Memorial now or Park Ridge because they're all been sent here because we have the stroke program here. They're all referred in to Dr. Devlin and his associates. But if you work here and if you get along with the neurologist, then you're going to see a fair number of people that come in with either TIAs or strokes. So that makes that carotid symptomatic. And I used to use the same flow velocity criteria and not operate on people until they had criteria of 70%. But recently I've seen some people that had clear strokes that in my mind were caused by carotid on that side. 60% stenosis with ulceration that we thought we saw on carotid arteriogram. Dr. Devlin orders a lot of carotid arteriograms. And I've done a fair amount of surgery in people that don't quite have a 70% stenosis because I think they're symptomatics on that carotid, and I've had good results and no recurrent strokes. So I think those are the criteria. Now, different people, depending on your age, different people have a different threshold to offer people carotid stenting. And that's gotten to be a pretty hot topic, and it was a pretty hot political potato here in this hospital going back about 10 years ago, because some of the people that do carotid stents are cardiologists, and some of the people that do carotid stents are interventional radiologists, and some of the people who do carotid stents are vascular surgeons. And so everybody was fighting over carotid stents. And the cardiologists 10 years ago and a lot of the radiologists were predicting that the surgeons who did open carotid endarterectomy was going to lose a lot of these operations to them who could put stents up. Well, there have been a lot of studies that have compared the results of carotid endarterectomies in good hands to carotid stents in good hands. And one of the things that make carotid stenting a more safe procedure is when they put the filter devices, so that if you dilate that artery and debris is otherwise going to go to the brain, you've got a filter sitting up there to try to trap that stuff, and you pull it out so that it doesn't go to the brain and cause strokes. That made a huge difference. That took the stroke rate with the carotid stent from 12 and 14% down to about 3%. And that was a huge advantage for carotid stenting. But still, if you look at the studies that compare carotid endarterectomy on the one hand, done by a guy that does a lot. Now, I'm not talking about a guy that does one carotid every 3 months. I'm talking about a guy who does 1 or 2 a week like I do. And compare that to a guy who does a lot of carotid stents. And I'm not talking about an occasional carotid stenter that puts one up every 6 months either. But somebody who does a lot of carotid stents like Sprouse and Lassar. The stroke rate is still 1 or 2% lower in the open carotid endarterectomy group. But what you will find, according to the literature, is that the ones that have the open carotid endarterectomies also have a slightly higher MI rate. So if you combine the stroke rate and the MI rate in the carotid endarterectomy group and compare that to the MI and stroke rate in the carotid stenting group, it's the same. So in the stent group, you have a higher stroke rate by 1 or 2%, but a lower MI rate. In the open carotid endarterectomy, you have a lower stroke rate, but a little higher MI rate, so it's about the same. There is literature out there that refers to the hostile neck. And a hostile neck can be a lot of different things. But, for instance, if you have somebody who's had a radical neck procedure for cancer, radiation for cancer or for anything, a tracheostomy right here, and you're trying to do a carotid endarterectomy here, somebody who's already had major neck surgery for whatever reason, you can run into scar tissue, a previous endarterectomy, somebody who has a nerve that's out one side of the neck and you don't want to operate on the other side and potentially run the risk of causing bilateral nerve deficits. These are things that they call a hostile neck. So those are indications sometimes to put up a carotid stent. I have a much lower threshold to put up a carotid stent than somebody else. I've just done a lot of open carotid surgery and I've had really good results doing it. And I'm pretty comfortable going into a hostile neck. And if somebody's had post-op radiation, some of my younger partners wouldn't think about going in and doing a first-time endarterectomy in a neck that's been previously irradiated, and I'll do it anytime you want me to do it. So it's just a matter of how you see it. I don't personally do carotid stents. If I have to do a carotid stent, I call on one of my younger partners who have done a lot of them, and we do them together. So we tag team it. And if they have a really hard open endarterectomy that they really want some help with, then sometimes they'll call me and we'll do it together. That's one of the beauties of our group, that if you need help and want help, or you want somebody to hold your hand doing something because you don't do it an awful lot, we've got people of all sorts of different experience levels depending on what the operation hand is. It just so happens I've done about 2,000 of these things, so I feel pretty comfortable going to a neck and doing a carotid endarterectomy. But I've got other partners like Sprouse and Lassar who've done 400 and 500 carotid stents, so they feel pretty comfortable putting up carotid stents. So, different people see it slightly differently.
Would a thyroidectomy patient be considered a hostile?
Not in my book. It might in somebody else's. And they say, yeah, the other ironical thing is they say older patients are higher risk, but the thing is older patients get kind of curvy. And when you're starting to put these wires up to do carotid stents, you bang off of walls and wires don't go quite as straight as you want them to. So the irony is, the older the patient, the more you may run into difficult architectural anatomy, and you might cause a stroke trying to put the stent up in an older patient. So people older than 70, relatively speaking, the irony is they ought to be a candidate for a carotid stent, but they actually are not as much of a candidate for a carotid stent, at least according to what the literature says. Let me just mention one other thing. You might be wondering what the stroke rate on a carotid is. For an asymptomatic patient, it would be 2 or 3%. For somebody who's had a stroke, I usually add 2% to that. If it's a huge stroke, I might add 4% to that. If you're operating early after a stroke for whatever reason, you might want to add 2% to that. If the carotid's out on the other side, you can add 2%. So if you have a really complicated carotid patient, you may go from an asymptomatic stroke rate of 2% to a symptomatic stroke rate of 8 or 10%. That's not 20%, but it's not 1% either. So there are high-risk patients and lower-risk patients, but I think, it's like a lot of things in life. You do what you have to do. I think you need to explain the risk and why you feel like the risk is a little bit higher, and then you just leave it up to the patient. Older people older than 80 have a little higher risk of stroke because their brain is not considered quite as stable a brain. So you can add 1 or 2% for a lot of different things. Anybody got another question? Well, we appreciate what you do. Hopefully you'll see a lot of patients coming through. I love to do carotids, and I appreciate your help taking care of them. If you're in MICU, I don't think you get very many carotids there, do you? Because they typically either go straight to a room for me, or they go to SICU or one of the other more traditional surgical units. I guess that's just where they go. But anyway, we appreciate your help. If you can think of any further questions, I'm wandering to the hospital a lot. Just holler at me and we'll try to answer them for you.
That was
Thanks.
excellent, Dr.
Thank you.